So hi everyone, I hope everyone can hear me online and live. I'm Marta Soares, I'm Senior Research Fellow at the Centre for Health Economics at the University of York. I work mainly in health economics, but I have a statistical training. The presentation today concerns evidence synthesis, and I'm just going to give you a brief introduction in the hope that you all know about the techniques used for evidence synthesis. So I'm going to give a brief context. It's just the structure of my talk. So a brief context. I'm going to identify and classify information sharing methods in evidence synthesis and explain a bit what they are. We're going to present an exploration on how methods compare using a case study. And I'm going to give an overview of a recent project that we got funded, and that's going to start soon on the same topic. And then I'm going to finish with some concluding remarks and hopefully discussion. Feel free to interrupt if you have any questions or clarifications as I go along. It's more a chat than a formal presentation anyway. So my background is health economics, as I've mentioned. And in health economics is part of a wider group of, say, assessments called health technology assessment. And it's done to support decision-making at several levels, but typically at health system level. So health system decisions need to often be made about the best use of healthcare resources. So which treatments, for example, which interventions, in which patients, when, meaning when in the disease pathway should a treatment be used, and whether in primary care, secondary care, etc. So there's a range of decisions that need to be made, and HTA assessments inform those decisions. So HTA has, simplifying, has two components really. It's an assessment of the evidence, the comparative evidence of clinical first set, and cost effectiveness second set. They're typically done separately, but there's obviously lots of links in between. So the evidence of clinical effectiveness is typically comprises of a review and a synthesis of clinical effectiveness studies. The cost effectiveness component aims to determine from the typically short-term, limited outcomes, relative effectiveness evidence aims to determine the long-term effects on population health, which are typically measured in quality adjusted life years. So as you can see, it combines kind of life expectancy with morbidity. And then in a second component, as the name cost effectiveness kind of implies, determines the overall cost implications to, in this case, relevant stakeholders, which might be health systems in this case, and patients in particular. So we typically consider together for cost effectiveness evidence from multiple sources and on multiple aspects of disease and treatment. So it kind of goes beyond the clinical effectiveness assessment, includes all the clinical effectiveness assessment measures, but extends from those in incorporating multiple sources of evidence, multiple aspects of disease and treatment, and we model those sources together. So we typically use decision modeling, which I'm not going to cover very much today, it's just for background. But decision modeling typically includes some evidence on disease progression. So in this case, a very simple model where treatment might be given at stable disease, patients might progress over time and die at some point in their pathway. So we model disease progression in this way. And assume some effects of treatment in some part of this pathway, so in some of these transitions that are assumed over time. And that allows basically extrapolating kind of patient outcomes and costs to the long term throughout the patient's lifetime. So you can determine the actual value of a particular intervention in the kind of its overall value basically for an individual patient. So there's models that might be more complicated, including more kind of health states, and models that might be combining different modeling approaches. So in this case, kind of a probability equation based model with a long-term kind of state transition model. So what do we do to inform these models? So we typically consider evidence. So these are all evidence-based approaches, and we consider evidence on disease progression to inform those kind of transitions and those progressions over time. Include a relative effectiveness parameter, one or more, which will be given by the kind of clinical effectiveness side, typically based on RCTs, but not necessarily. So randomized controlled trials. We include evidence on costs, on quality of life weights, which are just measures of how much quality you live your life in, and account for morbidity and structural. Obviously, in putting these models together, there's always structural uncertainty. So then we look for evidence to support those models, and that will include some form of empirical evidence, so sample-based studies in a range of these parameters can inform one or more of these. We also use mechanistic evidence to inform the structure of the model, and we always need judgments because obviously extrapolating to such long-term, typically lifetime of patient, usually requires some judgments. Put these together to give you your kind of model structure and the model inputs. And then there's obviously some consideration for the breadth and the quality of the evidence. So obviously, as you all know, have evidential uncertainty. So from the sampled studies, which is the uncertainty we're more comfortable, all of us more comfortable dealing with. But then there's a set of other uncertainties. So the evidence may be less representative, sparse, have lower quality, be not so relevant, or present some inconsistency. So studies might be inconsistent in their results for some reason. So we basically have to put all that together to make an assessment of cost effectiveness. So just a bit of background on uncertainty. So uncertainty in the evidence, as always, can result in uncertain outputs, which in this case means uncertain effectiveness and cost effectiveness estimates. So we're here more not just judging statistical significance, we're actually trying to establish, quantify the treatment effect. And what that means is that typically, if you think about drugs, these typically have a higher price, which implies a higher value. So the magnitudes of the treatment effect is actually important, not just that there is a treatment effect, it's just about the magnitude of it. So we've talked about the sources of uncertainty already, but to support these decisions, typically about which intervention is worthwhile using in whom, when, and what, we typically ground these decisions on expected values. And that's because rejecting an intervention that is expected to be beneficial just on the grounds of uncertainty is not justified ethically. So the decision is typically based on expected values. The key issue here is that under uncertainty, health systems may want to determine that further research needs to be conducted. So in case to reduce that uncertainty and reverse initial guidance if that is proven wrong. So that can avoid the consequences of uncertainty, the consequences of a wrong decision. So that means that approval and rejection in the context of health system decisions can be conditioned on research. Do you want to
get rid of the bar, maybe, because that helps you?
Yeah, that does help. Right.
Should do. Yes.
Yep, that's better.
Yes.
Thank you.
Sure.
So I guess down to the problem I'm here to discuss with you today. So what these processes, many of you might not be familiar with them, but what these are actually very formal processes for decisions about drugs, at least, and we can talk about other types of health technologies. So NICE, the National Institute for Clinical and Care Excellence, facilitates these assessments. So they pay academic groups, and New York is one of them, to review submissions from the pharma companies, where the pharma companies make their case for clinical and cost effectiveness. And these independent academic groups review that evidence, critique that evidence, and run further analysis if necessary. And then all those materials are presented to a group of decision makers at NICE, and they decide whether a certain drug is funded, so it's used within the NHS, or whether it's not used at all. So it's an adoption rejection decisions. They might require or ask for further evidence collection as well. So one of the key aspects is that in these assessments, these HTA, health technology assessments, evidence is sought directly on the PICOS. I don't know if you've came across this term, pertaining to the decision problem. That means we only include evidence on the population of interest, on the intervention and comparators of interest, on the outcome of interest, and with a particular study design, which is usually an RCT preferred study design. And what happens is that these appraisals are done indication by indication, and they're done as soon as the product is licensed has a marketing authorization. So it's quite early as the product is made available. So that means there's typically one single RCT, and that RCT often presents issues. So you might see, for example, limited evidence in the sense that that RCT doesn't connect well with the comparators in terms of a network of evidence. You might see single arm, the RCT might be single arm, so have problems not being comparative. The evidence might be complex in the sense that it might focus on a surrogate outcome and not actually present final outcome evidence. It might pertain to a complex intervention, which is really difficult to causality to be ascertained to each of the components of that intervention, or the evidence, the RCT might actually be very, very small, very sparse in the case of rare conditions, etc. So there are very often problems with the evidence being so close to marketing authorization. So the evidence is not really well developed. But it might be also the case that an extended evidence base might retain relevance. So what does that mean? So for example, chemotherapy is typically judged to work similarly across most solid tumors, for example, because it's a non-specific kind of type of treatment. It's just a blast. So why not use that external evidence, so external to the population that we're looking at, to support some assessments? So in some of these cases, extending the evidence base may be necessary to solve some of the issues listed, but may also be desirable in many of these cases. And this can strengthen decisions, avoid judgments and avoid errors, better characterize uncertainty and lead to better decisions. So just an illustration of what extending the evidence means. So you might have a set of studies represented here by these bubbles that are exactly on your PICOS, population, intervention, comparator, outcome, and study design. And so denoted here by 0, 0, 0, 0. So they're exactly on the population of interest on your PICOS of interest. But you might have a set of studies that look at the same treatment, same outcome, and same study design, but on a different population. So for example, for a different severity of disease. And you might think that that evidence is relevant. You might have another set of studies for the same population, but on a different treatment of the same class. So you might think that this evidence is relevant. Or a different outcome, so same population, same treatment, same study design, but on a different outcome that's not been considered here. Or you might have different study design, so like observational studies. This obviously gets more complex, as you might have different populations, so more than one alternative population, or you might look at evidence sets that consider combinations of these. So for this example here, you have study that looks at a different severity of disease and a different outcome. So this can be extended indefinitely, right? So here an observational study and a different outcome. So you can continue extending the evidence base. So what I'm going to present today is how do you use that extended evidence base and allow for some sharing of information across your desired kind of evidence set, your directly relevant evidence set, and indirectly, and the kind of external evidence sets, additional evidence sets that you might want to consider. So this is based on a work of a PhD student of mine, George Nikolaidis. And I think the thesis is currently embargoed because he embargoed it for publication, but he's happy to share if you email him. So the first piece of work is already published from his thesis. So it's identifying and classifying information sharing methods. And this pertains to what we've restricted the thesis at this point that we've started working on it to an evidence synthesis component. So we've restricted it, but it's much wider. There's much wider applicability than just meta-analysis or network meta-analysis. But for this work, we've just restricted it because it would have got really unmanageable. So for those of you less familiar with meta-analysis, so meta-analysis is typically done on the relative effectiveness side. So you have a single output you want to combine, typically a relative effectiveness measure, and you have multiple studies that you might wish to combine on that single measure. So in this case, it's the log odds ratio. So it's a logit model. So to pool those studies, you typically assume some form of likelihood for your number of events and out of the total number of patients. And this is for particular treatments in each arm of your study I. So treatment K in each arm of your study I. So the binomial is then ruled by a probability parameter, P, and that probability parameter is then modeled as a function in the logit scale as a function of your baseline for that study, and on a study-specific treatment effect delta here. The model I present here is a random effects model. So the study-specific treatment effects are being drawn from a normal distribution with a pooled common treatment effect D and a variance tau. So at this point, we might have the two evidence sets. So in this case, I've selected population. So imagine you have two evidence sets, one in population J equals 0, which is your population of interest, and another in J equals 1, the population that provides the indirect evidence. So this model here is not attempting to pool them, so it's a splitting model. So you retain the index J across the entire model. And obviously in a Bayesian kind of setup, you assign priors to the treatment effects. And this is all ruled by consistency equations, which just make everything link together. So that's just a form of an introduction. So we've reviewed NMA papers, so network meta-analysis, again, to try and constrain and identify, manage the literature review, because obviously sharing of information is really not something that's explicitly stated in these papers. So what George has done was to look through papers reporting network meta-analysis models. And he identified 89 papers where some form of sharing was used. And what is, before I kind of introduce the studies and what they looked at, what he's done was to try and identify core relationships that have been used to facilitate the sharing of information. So that means that, let's see if I can go back. The DJs have been related using some form of core, kind of a core relationship. So different models can fit into these core relationships, and we'll see a few. So he identified 4 types, so functional relationships, exchangeability-based relationships, prior-based relationships, and multivariate methods. And I'll go through these to give some examples. So functional relationships are no more than deterministic functions, often resulting in a reduced number of parameters. So some examples, lumping, so kind of directly combining the two, in this case, the two treatment effects for the two populations as if they were equal, or the variance parameters as well. But there are also examples of constraints being used. So assuming a strict inequality amongst parameters, so like D0 lower than D1, for example, as an example. Linear relationships, a lot of those, so meta-regression, for example, for bias adjustment or baseline risk adjustment, linear relationships across multi-component interventions, survival outcomes, dosages, etc. Also nonlinear relationships, for those more familiar with kind of early trials, those efficacy relationships like the Emax model is a nonlinear relationship that has been used previously in the literature. So the second type is exchangeability-based relationships, and he identified multi-level models, which assume that the different treatment effects on the different population sets, in the example I'm just using for simplicity, are drawn from a common kind of distribution. And that's been done in kind of class effect models. So I've briefly mentioned treatments of the same class. So treatments of the same class have been pulled together using multi-level models, but also across study designs as well, and different populations, and also random walk models. So random walk models assume that data points which are more similar with respect to a particular characteristic are expected to exhibit more similar relative treatment effects in the form kind of shown here. So that those models have been used to share across dosages of the same drug or across follow-up periods. The third type of core relationship that George found focused on prior-based relationships. So there's obviously kind of a Bayesian stamp to it, where you can use standard prior, so where the indirect evidence is used directly as a prior for your treatment parameter of interest and updated with the direct evidence. But there's a number of other models, more complex models that have been used. So mixture prior models. Mixture prior models are a mixture model between a vague prior. Let me see if I can point. Between a vague prior and an informative prior grounded on the indirect evidence set. The mixture parameters can be estimated within the model or assumed a certain value. He found commensurate priors. I have to say that he didn't find commensurate priors in this review, but he found them used for sharing IPD and aggregate data. But I've included them here because he's included them in the case study, so I've included them here. So commensurate priors are basically the case where the treatment effect of interest is centered to near the effect of both sources. So that means here the indirect treatment effect parameter, and where you apply a spike and slab prior to govern with a Bernoulli kind of likelihood to govern the extent of sharing. And then he also found power prior models. Power prior models are models that combine, in the likelihood, combine both direct and indirect evidence, but the indirect evidence likelihood is raised to a scalar that is between 0 and 1. And for power prior models, the alpha, the power parameter, can't be estimated from the data, so it has to be assumed. And it's usually analyzed by sensitivity analysis, so the value is varied. Multivariate models is also found. Some of those, I'm not going to focus too much on them today, and I'll tell you why in the next slides. But basically, the methods he's found differ in the way between and within study correlations are modeled. So I know those in the room can't see this table very well, but I'm not going to go through any of the details. So what this table presents is the PICOS levels, so intervention comparators, population outcomes and designs, and the 4 core relationships functional exchangeability-based, prior-based, multivariate, and then the references that George found for each of the methods, the models within each of the core relationships. So this is to say, I'm just going to summarize the kind of visual messages from this table. So sharing of information has been used across all PICOS levels to try and share across all PICOS levels. And all of these 4 core relationships obviously has been used. The attempts, the literature has a bigger volume in sharing across interventions. So you can see more references in the intervention kind of row. A lot of multi-level models have been used, but also a lot of constraints, lumping, linear and non-linear models kind of used for sharing information across interventions. Multivariate methods have been used to share across interventions, but they're mainly used to share across outcomes, as you'd expect. And I'm not focusing today on too much on outcomes, so that's why I'm not focusing too much on multivariate methods, but they've been used to share across interventions too. Prior-based relationships have been used mainly to share across designs, so RCTs and observational data. But other forms have also been used for sharing across designs like multi-level modeling. So I think the main messages are some relationships are used preferentially for specific contexts. So what does that mean? That means that if you share across an intervention, typically the papers you find go straight onto either some functional form, being lumping, or to some multi-level modeling. They don't consider prior-based approaches. So as you can see, there's no references here of prior-based approaches for sharing across interventions. Whilst when you look at sharing across designs, you see a lot more prior-based approaches and some multi-level modeling as well. And what this highlights basically is that there are a number of ways you can share information, and you need to consider all of them because they do impose different strengths of sharing. So by choosing a particular method, you are actually determining the level of sharing that's going to be used.
Did you try and categorize the papers in terms of where they were coming from, like from an academic setting versus more an industrial setting as well? Because I think a lot of this might be driven by, some of these papers would use the default formulation of the NMA model, which is in the guidelines, and then don't go into the extra details and complexity that, for example, having a mixture prior would embed in your model.
Yes, he didn't. Most of them were academic, actually. Mm-hmm. I think most of the prior-based models, and if I'm not there's hand raised, so if I'm not mistaken, most of them were actually in early trial design. Mm-hmm. Because in early trial design, the prior-based models are actually very frequently used. So in phase 2 studies to determine, mm-hmm. for example, groups of, I don't know, so for example, for hepatitis, I think they use prior-based models to define what genetic kind of components are, might the treatment be more mm-hmm. effective. So I think most of them are academic. There's very few industry ones. But the more innovative actually come outside of academia in some sense. So raised hands.
Since seems to be the rule that all early trials overestimate the effect size for one reason and another, often because they're underpowered, so you have the exaggerated effect size effect going on. I wondered whether it has ever been done for you to follow up after the event to see how accurate the estimates were of both cost and effectiveness, because I suspect that it will often be a bit over-optimistic.
Thank you, David. I don't know if you followed the question. So the question is whether model predictions have been followed up with longer term data to support, to see if the predictions are actually correct. I think that's,
Yes.
David, that's the question.
That's the question, yes.
I think they have in some cases, but it's usually quite difficult because once you approve a particular treatment, you lose all these evaluations are grounded on comparative effectiveness, on relative effectiveness, and once you approve for widespread use a particular treatment, it's not ethical to randomize to the comparator, so to the old agent anymore. So you lose the ability to collect data on relative effectiveness. So it is quite difficult to establish whether relative effectiveness predictions are valid in the long term.
Ah, yes, that's a pity, isn't it?
Yes, it is. That's why, yeah, there is some concerns and some questions, or some people are keen to sometimes withdraw approval or withhold approval until you actually gather the evidence you need to reduce uncertainty. But that it is a difficult decision, because if you expect something to be working for patients, it's not ethical to withhold it, even if your uncertainty is very wide. So yeah, it is difficult.
Yes, I mean, not nice judgments often seem to me to be clutching at straws, especially for typical things like chronic pain. You know, one guidance group says fringe things like acupuncture work, and the next one says that they don't. And it all seems a little unsatisfactory. Anyway, so
It is. It's there's in some types of interventions, particularly those softer interventions, the trial endpoints and the trial design and the heterogeneity in the data makes it quite difficult to actually put your finger on whether the treatment works or doesn't work. It's one of those complexities of the evidence base that yeah, very difficult to deal with.
Thank you very much.
So in terms of sharing of information, several methods are likely to be applicable to every different kind of context. The method will influence the degree of information sharing. And whilst a method selection could be informed by, for example, the plausibility of the assumptions imposed, the degree of information sharing imposed, or the ability to explore different levels of information sharing, there needs to be some form of judgment over whether information sharing is appropriate and whether it is, and what level of sharing should be implemented. So the second kind of chapter in George's thesis looked at how different methods compare using a single case study or a case study. So the case study was a project that I've worked on years ago of intravenous immunoglobulin for adults with severe sepsis and septic shock. So the main outcome on the clinical effectiveness was 30-day mortality, and there were 17 pairwise RCTs on IVIG, which is the short name for that thing, for that treatment. It's a strange treatment because it's a big protein. I don't know much about these, but it's a big protein, and everyone gives this IVIG to patients that are severely ill from sepsis, but no one actually knows how it works. So it's a bit of a strange one. So we found in that particular study, we found 17 studies on an adult population, which was the context of the project we were looking at. And as you can see, there's lots of heterogeneity. The random effects meta-analysis identifies a positive effect on mortality, but the evidence is very heterogeneous. The evidence base is very heterogeneous, with lots of small studies giving kind of very high treatment effects with unclear source for that heterogeneity. So we've explored, so that project was done in jointly with Nikki Welton in Bristol, and she's done a really thorough exploration of heterogeneity. So she looked at definition of treatments and treatment comparators. So what you see here in this slide is a number of models, so meta-analysis models. So for example, T3B indicates that it's a 3-treatment model in which the comparator was split into albumin, which is a real placebo, versus an inactive placebo, which is a clear solution. So albumin is cloudy, but seems to have some effect. It's similar to IVIG, so it's cloudy as well. So it's a true placebo in the sense that you can't distinguish between IVIG and albumin, but there's some activity to it. And then there's an inactive placebo, which is clear. So I think people can distinguish between the treatment and the placebo, but it is an inactive placebo. So she explored different treatment definitions. So she explored separating the types of placebo or pulling them together in a 2-treatment network. There's also 2 types of IVIG, which is trying to separate as well. But the best models were the models in this table that I'm presenting you. So the other thing she's explored was fixed versus random effects. Obviously, random effects describe but don't explain the heterogeneity. And she tried to explain the heterogeneity using meta-regression on a bunch of covariates of interest, including duration of treatment, which varied across the studies between 3 and 5 days. This was the best fitting model. So the 3 treatments, fixed effect, meta-regression on duration of treatment, but the clinicians didn't think duration of treatment was a clinically relevant source of heterogeneity. So we've retained the other 4 models because we couldn't justify the choice of this model based on clinical relevance. For the purposes of George's PhD, he has used only 2 of these 5 models. So he's used the best model, the fixed effects meta-regression on duration of treatment, and he's used the random effects model accounting for quality. So JADAD is a metric of study quality. But I think for the purposes here, one is a fixed effect model and the other is a random effect model. So there is a large body of evidence on the use of IVIG in children, so a different population, the P in PICOS. There's less heterogeneity. Children studies are much more regulated, so there's less heterogeneity in the evidence base. And there's a large negative publicly funded study, which is going to be relevant for some of our conclusions, which is here. So George looked at extending the evidence base to include children's study. He applied alternative models. So he applied splitting model, so only considering the adult evidence, lumping, which is the extreme, right? Considering they're equal, the relative effectiveness parameters across the 2 evidence sets. He considered hierarchical models, multi-level models, Priorbased, including standard informative prior, commensurate prior model, mixture prior models, and power prior models. And he considered sharing on the heterogeneity parameter, which I don't think I'm focusing here today very much. So I don't want you to read too much into this because I have other kind of summaries, but you can see here the adult evidence only in red and the combined, so pooled adult and children evidence together in green. And you can see that for the fixed effect models, most of the gray lines, so the other models will fall in between. So this is just the depiction of the distributions obtained for the relative effectiveness parameter across those models. For the power priors, you can see a nice gradient between splitting and pooling. So just on a bit more detail. So you have here forest plot type depiction. Again, those in the room might not be able to see these very well. But look at the lines in blue, which correspond to the fixed effect models. So that is the splitting model, and this is the lumping model. That's the relative effectiveness estimate you obtain when you just consider the adult evidence or when you pull both of them together. And what you can see is that the informative prior, as you'd expect, is similar, equal to lumping. It's just exactly the same as lumping them together. The multi-level model here and the commensurate priors retrieved actually distributions very similar to the splitting, so they didn't promote much sharing with the children's evidence, and the mixture prior is somewhere in between. So for the random effects models, which are the dashed black or gray, they should be all black, but appearing as black or gray, you can't see much because there's so much heterogeneity, and what we're showing here is a predictive distribution. So there's so much heterogeneity that there isn't actually, it's not clear how these relationships work, but there doesn't seem to be much impact of sharing. So now adding the power priors, so you can see that power prior with an alpha of 0 is very similar to splitting or equal, and a power prior with an alpha of 1 is equal to lumping. And somewhere with the range of alphas between 0 and 1, there's a gradient in between. So the same results, but using different metrics. So here you have in red, or what you'll see in the plot I'm showing, is the point estimate divergence. So it's the absolute difference in the posterior means between the model of interest and splitting. In green, the precision increase, which is 1 minus the ratio of standard deviations. And in blue, the Kullback-Leibler divergence, which is the level of information conveyed in one distribution in relation to another. And it's an information theory kind of grounded metric. So you can see that lumping obviously gives you a high kind of level of these 3 metrics. So in this plot, what you can see is those 3 metrics. So in red, green, and blue. And in the graph, so you have the axis here, which indicates the level of each of those metrics for the different models. And in the graphs, you have the power prior models for varying alpha. So the x-axis represents the alpha of the power prior. And you can see, so it's basically a different way to summarize the information presented before, where the point estimate divergence obviously only focuses on changes in the point estimate. The precision increase only focuses on changes in precision, and the Kullback-Leibler divergence metric should combine both precision and point estimate. And you can see that, yeah, so the power prior behaves as you'd expect: 0 close to splitting, 1 close to lumping. So with the random effects model, the power priors don't behave as neatly. So you can see here just the point estimate, so the mean of the predictive distribution that you obtained for different alphas, so depicted by the black line here. And you can see that the point estimate actually goes above the lumping post point estimate. And that's because, if you remember, it is because precisely because of this large study here. So the power prior is actually at an alpha of 0.2 or to 0.25 or something, is actually drawing inference towards the result of this study here. It's attributing it a really high weight and a really low weight to the remaining studies. So that is the estimate for that Brockhurst study. So it kind of goes beyond lumping, obviously beyond splitting. And that's what you can see in the same graph as the previous one, but for the random effects model. You can see that lumping is sort of around here for both point estimate divergence, and for the callback libeler divergence, and here for the precision increase, and that the power prior goes beyond that for kind of alphas of 0.2 to 0.5. And then it converges onto lumping at alphas higher than close to 1. So there's a bit of an expected behavior there with the random effects model. So we've also looked at the impact on decision making. So I'm just taking note of the time. And we've built, so in the original project, actually, there was a decision model quantifying costs and qualities and value of information metrics, which quantify the expected consequences of an incorrect decision, which give you a measure of the value of further research. So I'm going to be brief on these, hoping most of you will have heard of these, but if not, it just quantifies the expected value of a wrong decision based on some loss function, which is given by the cost effectiveness model anyway. So it's quite straightforward to compute. So you can see here in this graph that if you split, so basically consider only the adult evidence, which is what we've done in the original project, you'd be borderline between approve and reject. So in green, you have the approve area, and in red, you have the reject area. So there's some explicit criteria set up by NICE on when to approve and when to reject a particular treatment based on value for money, based on cost effectiveness. As you share from the children evidence, because as you share more with either the power prior or with some of the other models that we've considered, you'd veer towards the rejection side, because the children's evidence doesn't provide such a high magnitude of treatment effect. So there is a significant impact on decision making. There could have been a significant impact in decision making if the children's evidence had been used. The random effects model, this is a little one because I have the full one next slide, but just for you to see that as we've seen, the impact of sharing isn't that wide, as you've seen from the actual distributions of the relative effectiveness estimates. And as you remember, lumping, kind of the power prior approach gives you estimates higher, kind of more further away from lumping.
But presumably you have much smaller cost effectiveness curves in this case with the random effects, because you have more uncertainty. So you're less sure of the optimal decision, although on average you're there.
Yeah. Yeah, much more uncertain, definitely. So value of information. So what this gives you is the value of conducting further research in pounds, basically, which could be in health as well. So this is the kind of health or money lost on average from the potential consequences of a wrong decision. And what you can see is that the value is higher for the splitting model, that's fixed effects, because it was borderline, if you remember. So that's when the value of your research is higher. It's because you're really unsure about which is the right decision to make. And then obviously, as you go along this line, you are farther away from the approval. So that means you're more certain that you're going to reject. So as we'd expect, the kind of lumping approach where you fully combine with the children's evidence gives you no value of information at this level of threshold, which is that value for money estimate that decides adoption or rejection that I've mentioned before. So I'm not going to dwell too much on this, but this is basically an extension of those analyses to consider the value of sampling information, so a particular study design on relative treatment effects. And the same, you can see the same here, sample size is 2,000 patients, doesn't matter, but that's to say that a study is worthwhile, an RCT with a particular design is worthwhile across a number of power prior alpha values, but it's not worthwhile if you're sharing a lot with the children's evidence. So if your alpha values are higher. So how do methods compare? So we've seen that alternative information sharing methods return different relative treatment effect estimates, and they have important policy implications. The relationship between the true relative treatment effects is unknown, but the plausibility of sharing information shouldn't be determined by the data alone. So there needs to be a judgment on the plausibility of the sharing. Measures of statistical fit are not appropriate, and I'm running short in time, so I'm going to skip some of this. But statistical fit is really inappropriate here in this case. And the other important conclusion is that whilst lumping and splitting can be used to anchor the spectrum of strength of sharing, they can't define its bounds, as we've seen by the power prior example, where for some power prior alphas, the estimate was above the estimate of lumping. There's some conclusions grounded on the case study, but again, they're not generalizable, so they depend on features of the data, but things like commensurate prior or multi-level models impose only subtle information sharing. So that might not be true for all cases. Obviously, we only have 2 evidence sets, so to define a multi-level model with 2 data points won't give you much sharing, so it might not be the case across other examples. But it was a nice way to demonstrate that these methods can give you very different strength of sharing. So just briefly going to mention, we have a new project starting funded by the MRC, and that's in collaboration with others in New York and Leicester. And it's about multi-indication evidence synthesis in oncology, and it basically uses sharing of information to facilitate this multi-indication analysis. And what we've proposed, I'm going to skip through some of this, again, in the interest of time. But basically, as I've mentioned, NICE has an indication by indication appraisal. It's very obvious in oncology because there are now multi-indication drugs. So for example, pembrolizumab has already been through 17 appraisals, and there's 45 forthcoming. The next one, you'll have a trial that is very small, and it's going to ignore all the evidence that was considered in the 17 that already occurred. So it feels that we're not using best using the evidence we have on pembrolizumab. So what we're going to do is first devise ways to present the multi-indication evidence that is very complex in oncology, as some of you might know, with multiple outcomes, maturity of evidence, it's time to event, typically time to event, or survival type methods. So we're going to identify the evidence and present it in evidence maps, but we need to extend the methodology for evidence maps if you know about it. We're going to focus then on the synthesis, on the evidence synthesis on prior mixture models and hierarchical mixture models, and that's because we want external judgments on the appropriateness of sharing. But we have to extend these methods not because they don't really exist for the types of data structure. And the type of data structure here is going to be NMAs nested within an indication. So it's not really been done before. So we're going to extend those, and we're going to devise methods for making explicit the level of sharing. We didn't find Kullback-Leibler to be a very useful metric. There's no intuitive interpretation to the values it provides. So we need to find another metric to be able to summarize strength of sharing. And then we're going to run a simulation study, not just to compare methods, but also to explore the circumstances where sharing of information from overall survival evidence or from surrogate relationships can lead to a more efficient and unbiased estimate. So one of the critical aspects here is that some studies and some indications will present overall survival evidence, which is what we'd want. And that's because there are much more cancers that have a higher mortality rate. For cancers with a longer survival expectation, the trials will be based on surrogate relationships. And so the evidence base is quite complex. If you are using a range of indications, then you need to consider whether you should share on surrogate relationships or whether you should share on overall survival. And so our simulation study will look at the data structures where sharing on surrogates might be more appropriate than sharing on overall survival. We're gonna focus as well on elicitation. We need to elicit expert judgments. There's no methodology for elicitation. And we're going to look at the impacts on cost effectiveness and decision making of these developments. We're going to then at the end make a set of recommendations and offer a set of tools to support these decisions in practice. So I think my main messages, I think I've put them across. So sharing of information is essential. It has been used kind of haphazardly without great thinking about the method and what about the level of sharing that the method implies and the data structure implies. And there needs to be better consideration of the level of sharing, either by choosing a method that for some reason is judged appropriate, or by including external judgments on what the appropriate level of sharing is. And that's mainly kind of to raise awareness of this. So I think we're going to end here and maybe have time for some questions, maybe one or two.